Imagine a joint in your body that, well, routinely generates enough force to crack open a walnut.
Right.
A joint that fires literally thousands of times a day.
Yeah.
Every time you speak, swallow, or chew.
Yeah, it's a massive workload.
Exactly. And now, imagine that this high-powered, force-generating structure sits just millimeters below your brain.
It's quite terrifying when you think about it.
It is, because it's separated by a shelf of bone so incredibly thin it's practically translucent.
Yeah.
Logically, one wrong move, one hard bite on a piece of ice, and that joint should just crush straight upwards into the cranial cavity.
But it doesn't.
It doesn't. And today, we're going to explore the absolute architectural miracle that stops that from happening.
It's a profound mechanical paradox, really. We're dealing with a structure that must be incredibly robust to handle these immense masticatory forces.
Yeah.
But it's situated in a remarkably delicate anatomical neighborhood. You just cannot study this region the way you study, say, a simple hinge joint in the limb.
Which is exactly why we're setting a very specific mission for you, the listener, today. Whether you are a medical student navigating your early clinical years, a surgical or dental trainee staring down your board exams, or just a seasoned clinician revising your applied anatomy, we are going into the deep waters.
Absolutely.
We're using Chapter 13 of the textbook of Head and Neck Anatomy by Hyatt and Gartner as our structural spine for this deep dive. But our goal is entirely conceptual.
Right, because rote memorization of origins and insertions will completely fail you.
Exactly. It fails you when you're actually standing at the dental chair or in the operating theater. So we're here to build a robust, three-dimensional mental model of the temporomandibular joint, the TMJ.
Yeah, we want to look at how its architecture operates entirely in service of function and how that structure ultimately dictates disease, intervention, and, well, patient outcomes.
I think framing it around structure dictating function is really the only valid way to approach head and neck anatomy.
Oh, without a doubt. If you look at the deep face, the heavy musculature of the masseter and temporalis, the dense vascular supply, the trigeminal nerve networks, that entire complex is the engine.
The engine, right.
It provides the raw, unrefined power.
So if the deep face is the engine, then the temporomandibular joint, that has to be the gearbox.
That is a highly accurate way to visualize it, yeah.
Because the gearbox doesn't generate force itself, does it? The TMJ is not a motor.
No, not at all.
It directs force. It takes that raw, brutal power from the chewing muscles and translates it. It transforms muscle contraction into controlled motion.
And it transforms crude force into precise dental alignment.
Right, transforming movement into vital human functions. Chewing, speaking, airway maintenance.
And we really have to add a critical caveat to that gearbox analogy. It performs this highly coordinated translation of force in two places at once, perfectly synchronized.
Two places at once, because, well, we're never just talking about one TMJ.
Never. If we connect this to the wider principles of orthopedic anatomy, the TMJ basically shatters the usual rules.
How so?
Well, normally, if you look at a synovial joint, say, the knee or the shoulder, it operates with a degree of mechanical independence. You can severely injure your left shoulder without instantly altering the core resting biomechanics of your right shoulder.
Right, they operate separately.
Exactly. But the TMJ defies that independence entirely because the right and left halves of the mandible, the lower jaw, are mirror images permanently fused together into a single solid bone.
It's just one continuous, rigid piece of hardware sweeping across the lower face.
Precisely. Therefore, the temporomandibular articulation cannot be viewed as two separate entities. It is a single, unified, bilateral system.
So if you move one side,
you cannot initiate a movement in the left TMJ without instantaneously forcing a reciprocal movement in the right TMJ. A disruption on one side, whether it's a muscular spasm, an arthritic degradation of the cartilage, or a displaced disc, it inextricably alters the biomechanical load on the other side.
Because they're permanently married by the mandible.
Exactly. They are mechanically locked together.
Okay, so we have this bilateral unified gearbox. Let's start building our 3D model of this system from the ground up, starting with the physical hardware, the core anatomical framework. Let's focus on the mandible first.
Well, the mandible holds a rather unique status in the cranium because it is the only freely moving bone of the entire skull.
If we exclude the tiny ear ossicles, right?
Right. Excluding those. Everything else in the skull is heavily sutured together, locked into this rigid architectural dome. The mandible is the solitary, massive moving part suspended beneath it.
And for our purposes, our focus narrows down to the very superior extremities of this bone.
Yes, the condylar
The
processes.
heads of the mandible, the actual physical surfaces that make contact and drive into the skull base.
The condyles, exactly. And the geometry of these condyles is, well, it's essential to understand because it dictates the entire envelope of motion.
Mhm.
The text describes them as being classically football-shaped.
And just to clarify for global listeners, we are talking about an American football or a rugby ball here.
Right.
An elongated, oval, elliptical shape. Not a perfectly round sphere like a World Cup football.
An ellipsoid, yes. And the dimensions are highly specific. They measure approximately 20 millimeters through the long medial-lateral axis.
So that's from the inside near the midline out towards the ear.
Exactly. And about 10 millimeters through the anteroposterior axis, meaning from front to back. So they are roughly twice as wide as they are deep.
You know, I actually found this next point quite counterintuitive when I first looked at the anatomy.
Oh, how so?
Well, I always pictured the jaw swinging straight up and down, mounted on a perfectly straight horizontal hinge, like a standard door hinge mounted on a wall.
Ah, I see.
But the text highlights a fascinating geometric fact. These elongated football-shaped condyles, they do not sit perfectly straight across from one another in the horizontal plane.
No, they don't. They sit at a distinct oblique angle.
Right. The text notes that if you were to draw an imaginary line through the long axis of both of these condyles and extend those lines inward and backward, they would intersect precisely at the anterior border of the foramen magnum.
The massive opening at the base of the skull where the spinal cord exits.
Exactly. So why are they angled like that? What is the evolutionary or mechanical benefit of pointing the condyles inward toward the spine?
Well, you have to think about the physical space the jaw is occupying and the arc of motion it needs to achieve. If the condyles were perfectly parallel to each other, like your door hinge analogy, the mandible would only be able to perform a simple, rigid opening and closing motion.
Just up and down.
Just up and down. But human mastication requires grinding. It requires lateral, side-to-side sweeping movements to crush fibrous food. So that oblique angulation allows the condyles to pivot and glide along the curved cranial base without colliding with other structures like the mastoid processes. It creates a cone of rotation that accommodates the complex, multi-directional sweep of the jaw, all while maintaining structural stability against the skull.
It's a pure adaptation for complex movement. It's brilliant. Okay, so we have these angled ellipsoid condyles. Let's look at where they actually plug into the skull.
Good idea.
And I am going to challenge the conventional visual here, because when you look at a bare human skull from the underside, it looks incredibly obvious.
It does, yes.
There is a deep, hollow, very obvious pocket on the temporal bone called the mandibular fossa, or the glenoid fossa. It visually looks like the mandibular condyle is meant to nestle directly up into that deep pocket.
That's the logical assumption.
Right, so logically you would assume that when you bite down hard, all that biting force is driven straight up into the roof of that deep fossa. It looks like a classic ball and socket setup.
And that visual intuition is exactly why this is one of the most pervasive clinical misconceptions, even among early trainees.
Wait, so it doesn't take the force?
Not at all. You have to look at the histological density of the bone in that fossa. The bony roof of the mandibular fossa, the deepest part of that pocket is paper thin.
How thin are we talking?
Well, in many dried anatomical specimens, if you hold the skull up to a light, that roof is literally translucent. Light shines directly through it.
Oh, wow.
Yeah. And you must consider what lies immediately on the superior side of that paper-thin bone. It is the middle cranial fossa, the temporal lobe of the brain.
So going back to my opening scenario, if you were driving the force of a crushed walnut straight up into that socket,
You would drive the condyle straight through the skull base and into the cranial cavity.
that's horrifying.
Indeed. It is completely architecturally incapable of bearing any mechanical stress whatsoever. It is merely a housing space, not a loading zone.
Okay, if that deep pocket isn't taking the hit, where does the massive force of chewing actually go? We have to redirect it somewhere thick and strong.
The entire system shifts forward. The functional articulation and the force loading occur anteriorly. When you actually engage the jaw and bite down, the condyle does not sit up in the deep bowl.
Where does it go?
It moves forward and is positioned against the thick, robust, convex posterior slope of the articular eminence.
Let's trace that force vector so you, the listener, can really map this in your mind. You have the deep, fragile bowl of the fossa.
Right.
Just in front of that bowl, moving towards the face, the temporal bone slopes downward into a thick, strong, bony ridge.
Yes, that's the articular eminence.
And it is the downward slope of that ridge that acts as the heavy-duty loading ramp. That is what absorbs the mechanical stress of your jaw, not the deep bowl.
Spot on. Radiographic imaging, particularly MRI and cone beam CT scans of functioning joints, absolutely confirms this. The stress-bearing articulation is entirely against the slope of the articular eminence.
That completely flips the mental image. It is not a ball resting in a cup. It's a ball pressing upward and forward against a sliding ramp.
Exactly.
But mechanically, that creates a massive problem. We have the convex, football-shaped condyle of the mandible, and it is pressing against the convex, rounded slope of the articular eminence.
Two convex surfaces.
You cannot have two convex, rounded surfaces articulating efficiently under heavy load. They would just roll off one another. The surface area of contact would be a single point, which would concentrate the force and destroy the bone.
Which brings us to the structural mediator, the absolute genius of the system, the articular disc.
Let's dive deep into the articular disc. This is the dense, fibrous connective tissue plate interposed between the two bones. It has to solve the problem of these two incompatible convex surfaces.
Its topography is custom engineered to solve exactly that problem. It essentially acts as a shape-shifting interface.
Let's examine its surfaces.
Well, the inferior surface of the disc, the bottom side that constantly touches the moving mandible, is purely concave. It forms a shallow, smooth cup to perfectly cradle the convex head of the mandibular condyle.
That makes perfect sense. Convex bone fits into a concave cup. What about the superior side, the top side facing the skull?
The superior surface is far more complex because it has to match two completely different environments. It is concavo-convex.
Concavo-convex. Let's break down that morphology.
It basically changes shape depending on the zone. Posteriorly, toward the back of the joint, the superior surface is convex. It bulges upward so it can fill the hollow, fragile concavity of the mandibular fossa.
Okay, so it fills the bowl.
Right. But as you move anteriorly toward the front, it transitions into a concave trough. This allows it to slide smoothly against the heavy, convex slope of the articular eminence.
So it is essentially a custom-molded saddle. It perfectly fills the negative space between a moving, complex jawbone and a stationary, complex skull base.
Yes, and its internal tissue properties are just as highly specialized as its external shape. If you take a sagittal cross-section of the disc, you will see it is not uniformly thick.
It has different zones.
It's divided into three distinct bands. It is thickest at its posterior border, moderately thick at its anterior border, and dramatically thinnest right in the central intermediate zone.
And that thin central zone is the primary stress-bearing area, isn't it? That is the exact point that gets squeezed relentlessly between the condyle and the eminence during a heavy bite.
Yes, it is. And because it is under such immense constant mechanical compression, that central thinnest portion of the disc has adapted in a very specific way.
How so?
It is entirely avascular, it lacks any blood vessels, and it also lacks nerve innervation.
Wait, I need to understand the physiology there. If you have dense fibrous tissue that is constantly working and bearing load, it needs oxygen. It needs nutrients. If it has no blood supply at all, how does the tissue survive? How does it not just necrose and die?
This is where we see a brilliant biomechanical adaptation called weep lubrication or synovial pumping.
Synovial pumping.
It relies entirely on the synovial fluid that bathes the joint capsule. Because there are no internal vessels, the movement of the joint itself acts as a mechanical pump.
So chewing pumps the fluid.
Exactly. When you bite down and compress the disc, fluid and waste products are physically squeezed out of the fibrous matrix. Then, when you release the bite, the tissue expands slightly, and fresh synovial fluid, which is rich in nutrients, is sucked back into the avascular fibrous tissue. The mechanical act of chewing is literally what keeps the disc alive.
That is incredible. The pressure that would normally destroy a blood vessel is the exact same pressure required to pump nutrients into the tissue.
Again, nature's engineering.
Now, what about the edges of the disc? Are they also avascular?
No. Conversely, the periphery of the disc, and particularly its posterior attachment, an area known as the retrodiscal tissue or the bilaminar zone, is highly vascularized. It's packed with an extensive venous plexus, arterial supply, and dense sensory nerve endings.
Okay, so this central thinning of a disc. The textbook mentions that in older individuals, the disc can actually become perforated right in that avascular thin center. Given everything you just said about the loads it bears, a hole in the middle of the disc sounds catastrophic.
It is a significant pathological event, yeah. And it is a direct consequence of a lifetime of mechanical wear. You've got to think of it like the tread wearing down on a vehicle's tire, but over decades.
Right.
You're opening, closing, grinding, and biting millions of times over a lifespan. If the biomechanics are slightly off, or if the patient suffers from severe bruxism teeth grinding, that avascular thin central zone can wear entirely through.
Which leads to bone-on-bone contact.
Exactly, or at the very least, severely altered grinding joint mechanics.
It's astounding to think about the sheer kinetic mileage we put on this tiny saddle of tissue. Speaking of the tissue itself, the articular coverings of the bones in the TMJ are highly unusual compared to the rest of the skeleton, aren't they?
They are entirely unique. If you look at almost every other freely movable synovial joint in the human body, the hip, the knee, the finger, the articulating surfaces of the bones are covered in hyaline cartilage.
Right, which is glassy, incredibly smooth, and designed to reduce friction.
Yes. But the adult TMJ is fundamentally different. The articulating surfaces of the temporal bone and the mandibular condyle are not covered by hyaline cartilage. They're covered by dense, avascular, collagenous connective tissue overlaying a deep layer of fibrocartilage.
Why does the body abandon the glassy hyaline cartilage here? Why use fibrocartilage instead?
Because of the nature of the forces, hyaline cartilage is excellent at resisting pure compressive loads. But the TMJ isn't just compressing. It is grinding, sliding, and shearing.
So it needs something tougher.
Fibrocartilage, with its dense bundles of collagen fibers, is vastly superior at resisting the complex, multidirectional shear forces generated during mastication. But more importantly, it is what lies deep within this covering that makes it so remarkable.
The text mentions a thin, proliferative layer of cells sitting just beneath the surface. Proliferative, meaning they have the capacity to multiply, to generate new tissue.
Yes, and this is why the TMJ is so uniquely resilient. Unlike hyaline cartilage, which has famously poor healing and regenerative capacity, these proliferative cells in the TMJ can be activated to functionally remodel the joint throughout your entire adulthood.
Wait, so the TMJ is not a static piece of architecture that simply erodes over time?
No, not at all. It actively biologically responds to its mechanical environment.
So if a patient's function changes, say they have significant asymmetric tooth wear, or they undergo extensive orthodontic work that shifts their bite, or they lose several molars on one side, the joint actually changes its shape to accommodate.
Precisely. That proliferative layer detects the altered mechanical stress and kicks into action. It actively reshapes the bony contours and the articular surfaces to adapt to the new kinetic reality. It's the ultimate real-time example of Wolff's law bone and tissue adapting to the loads placed upon them.
That dynamic remodeling is fascinating. Your jaw joint is essentially renovating its own architecture to match how you are currently chewing.
Exactly.
Okay, so we have our bones, and we have the shape-shifting, nutrient-pumping disc in between them. But if we just had bones and a disc, the jaw would simply fall right off the base of the skull.
Right, we need enclosures.
We need restraints, we need the joint capsule, and the ligamentous network. Let's build the packaging that seals this system.
The foundation of that packaging is the joint capsule. It's a loose, thin sleeve of dense, irregular, collagenous connective tissue that completely envelops the articulating region.
And where does it attach?
Superiorly, it attaches to the temporal bone, tracing the entire circumference of the mandibular fossa and wrapping anteriorly around the front of the articular eminence. Inferiorly, it drops down and forms a tight collar around the anatomical neck of the mandibular condyle.
So it creates a completely sealed, fluid-filled balloon encasing the bones in the disc.
Yeah.
But it is not just one big empty room inside that balloon, is it?
No, and grasping this specific architectural detail is perhaps the single most crucial concept for understanding how the TMJ achieves its complex movements.
That's so.
The articular disc does not just float freely in the middle of the fluid. The entire outer circumference of the disc is firmly attached to the inner walls of the joint capsule.
So it spans the entire width and depth of the space.
Exactly. Because it attaches to the inner walls all the way around, the disc physically and completely divides the joint capsule into two entirely distinct, isolated cavities. It compartmentalizes the joint.
You essentially have an upstairs and a downstairs.
In anatomical terms, you have a superior synovial compartment, the space above the disc, bounded by the temporal bone, and you have an inferior synovial compartment, the space below the disc, bounded by the mandibular condyle.
And the synovial fluid in the superior compartment does not mix with the fluid in the inferior compartment. They are sealed off from one another.
Unless there is a pathological perforation in the disc, they are completely separate. And this physical separation is the literal anatomical basis for the joint's dual types of movement.
Right.
The two compartments handle entirely different mechanical jobs. We will break down that choreography shortly, but you must fix that image in your mental model. The disc splits the joint horizontally in half.
Okay, so the capsule holds the synovial fluid in, and it houses the disc.
Mm.
But the capsule itself is just a sleeve of connective tissue. It is relatively loose to allow for movement. It's not structurally robust enough on its own to keep the jaw from violently dislocating under heavy force. That is where the ligaments come in.
Ligaments are the ultimate restraints. Their primary physiological role is to restrict excessive destructive ranges of motion. And the most prominent heavy-duty restraint in this system is the lateral ligament, also formerly known as the temporomandibular ligament.
When I looked at the description of this lateral ligament, I'm struck by how sophisticated it is.
Huh.
It's not just a single thick strap of tissue slapped onto the side of the joint.
No, not at all.
It is actually a pronounced thickening of the lateral aspect of the joint capsule, and it is divided into two distinct bands of fibers that perform two entirely different safety functions. Let's break those down.
Sure. The outer portion is the superficial layer. It's a broad, fan-shaped band. It originates from the articular tubercle of the temporal bone and drops obliquely downward and backward to insert on the lateral aspect of the mandibular neck.
What's its main job?
Its primary vector of resistance is designed to prevent the jaw from swinging too far laterally, too far down, and causing the condyle to drop out of the joint.
So the broad superficial band limits downward and sideways excursion. What about the inner, deeper band?
The deeper band is smaller, situated more medially, and its fibers run in a completely different direction. They run almost horizontally, straight across from the articular eminence to the lateral pole of the condyle.
Horizontal fibers.
Yes. This horizontal band has a very specific critical job. It prevents the condyle from being driven posteriorly.
Wait, posteriorly, meaning driven backwards?
Precisely. Let's connect this right back to our very first observation about the skull base. The roof of the mandibular fossa is paper thin. It separates the joint from the brain.
Right, the translucent bone.
The deep horizontal band of the temporomandibular ligament is the physical, high-tensile safety chain that stops the condyle from violently retracting and smashing through that fragile bony plate.
Oh, wow.
When a traumatic force hits the front of the chin, pushing the jaw backward, that horizontal band snaps taut and absorbs the kinetic energy before the bone hits the skull base.
The deep horizontal band is the safety chain protecting the brain. That is absolute architectural elegance.
It really is.
But looking at the text, I have to challenge the symmetry here. The textbook points out this incredibly robust, dual-layered lateral ligament on the outside of the joint. But it explicitly notes that there is no corresponding equivalent capsular ligament on the medial side, the inside of the joint facing the airway.
That's right.
Why the asymmetry? The body usually loves symmetry. Why heavily reinforce the outside but leave the inside relatively unprotected?
It is a brilliant observation, and the answer requires us to zoom out and look at the mandible as a whole. If you try to analyze the TMJ as an isolated single joint, that medial weakness makes zero mechanical sense.
Exactly.
But remember, our foundational rule, the TMJs, are a unified bilateral system. The right joint and the left joint are rigidly, permanently connected by the massive, solid bone of the mandible itself.
Oh, I see the physics of it now.
The structural unity of the jaw makes a thick medial capsular ligament completely mechanically redundant. Imagine a lateral force hits the left side of your jaw, trying to push your left condyle medially inward toward your throat.
Right.
Because the mandible is a rigid beam, that inward force on the left is instantly transferred across the chin to the right TMJ, pushing the right condyle outward. And what stops the right condyle from moving outward? The massively strong lateral ligament on the right side.
The jaw acts as a solid cross brace. The right outside ligament protects the left inside joint and vice versa.
Exactly. The opposing joint provides the structural countertension across the midline. It's a masterpiece of load distribution.
Now, beyond the capsule itself, the text details two other ligaments, referred to as accessory ligaments. They aren't attached directly to the joint capsule, and they seem almost vestigial, but they play a role in the broader kinetic web.
Yes. First, we have the sphenomandibular ligament. You have to look at the developmental history to understand why this structure even exists. It's actually an embryological remnant.
From when the jaw was forming.
Exactly. During the development of the first pharyngeal arch in the embryo, a structure called Meckel's cartilage forms the template for the jaw. While the proximal part of this cartilage eventually turns into the tiny malleus and incus bones in the middle ear, the perichondrium, the sheath surrounding the middle portion of the cartilage, remains and thickens. This becomes the sphenomandibular ligament.
So it's evolutionary and developmental ghost. Where does it attach?
It runs from the spine of the sphenoid bone at the skull base down to the lingula, which is a small, sharp, bony projection located on the medial, inside surface of the mandibular ramus, right next to where the main nerve enters the jaw.
Does it do much functionally?
Mechanically, it doesn't provide massive support, but it acts as a swinging tether to help limit excessive lateral mandibular movement and acts as a pivot point during opening.
And the second accessory ligament is the stylomandibular ligament.
Right. This is not even a true ligament in the traditional sense. It's actually a highly specialized, thickened band of the deep cervical fascia.
Okay.
It extends from the styloid process, that sharp, needle-like bone projecting down under the ear, and fans out to attach to the posterior border and angle of the mandible. Its primary role is to act as a posterior tether, assisting in limiting extreme anterior protrusion, essentially stopping you from jutting your lower jaw too far forward out of the socket.
Okay, so we have all of our engine components laid out on the table. The angle bones, the divided capsule, the convex pumping disc, and the bracing ligaments. Now let's put it all together and look at the functional integration. Let's see this bilateral gearbox in motion.
The fun part.
The textbook uses an intimidating multisyllabic classification to describe this joint jingly morthordial.
It is quite the mouthful. But if we break down the etymology, it is essentially the blueprint of how the joint operates. Jinglemus is derived from Greek, meaning a simple hinge joint,
Okay, hinge.
and arthroidal refers to a freely gliding or sliding joint. Therefore, the TMJ is a jingly morthordial joint. It must hinge and it must glide to complete a full range of motion.
And this duality links directly back to that most critical structural feature we discussed earlier, the articular disc dividing the capsule into two compartments. The division of biomechanical labor is absolute.
Exactly. The inferior compartment, the isolated space downstairs between the mandibular condyle and the bottom of the disc, handles the jinglemus function. It is solely responsible for the rotatory, hinge-like movement.
So the condyle just spins.
The condyle simply spins or rotates against the concave undersurface of the disc.
Meanwhile, the superior compartment, the isolated space upstairs between the top of the disc and the temporal bone, handles the arthrodile function, the translatory gliding movement. In this compartment, the disc and the condyle move together as a single unit, sliding forward and downward along the slope of the articular eminence.
This functional division is what gives the human jaw its incredible, unique arc of motion. So let's trace the biomechanics of everyday human actions. Let's start at the baseline, doing absolutely nothing, the resting position of the mandible.
The text defines the resting clinical posture very specifically. An upright head posture, the heavy masticatory muscles are relatively relaxed, so the lips are lightly touching to maintain a lip seal, but the teeth are definitively separated.
Yes.
There is a continuous 2 to 4 millimeter vertical gap between the upper and lower teeth, known as the freeway space or interocclusal clearance.
This is crucial for dental and joint health. Your teeth should not be constantly clamped together. At rest, there must be this vital freeway space. In this resting state, the condyles are not slammed up into the fossa. They are resting passively, slightly forward, against the posterior slope of the articular eminence.
So from this resting freeway space, let's initiate opening the jaw to take a bite of food. It is not just the jaw passively dropping open like a trapdoor. It's a beautifully choreographed, active sequence.
To open the mouth widely, you cannot just hinge the jaw open. If you only use the hinge movement in the inferior compartment, the angle of the jaw would violently swing backward and crush the parotid gland, the external carotid artery, and the vital structures of the neck.
You have to move the whole apparatus out of the way.
Precisely.
So how does it avoid crushing the neck?
By combining the movements, when you initiate opening, the lateral pterygoid muscles, which sit deep in the face, contract. They pull the neck of the condyle and the articular disc forward. This is the translatory glide in the superior compartment.
Sliding down the ramp.
Exactly. The condyle and disc slide down the slope of the eminence. Simultaneously, the depressor muscles in the neck pull the chin downward, causing the condyle to rotate against the disc in the inferior compartment.
This simultaneous combination, gliding the top of the jaw forward while hinging the bottom of the jaw downward, creates a dynamic center of rotation.
Yes. It shifts.
The axis of movement isn't at the joint itself, it shifts down into the middle of the mandibular ramus. This creates a suspension effect, allowing the mouth to open wide while the back of the jaw cleverly drops down and avoids compressing the neurovascular structures of the neck.
It's an elegant spatial solution to a complex anatomical problem. Now let's look at the muscular control of that freeway space we mentioned. The text notes a fascinating physiological detail. The lateral pterygoid muscles and the elevator muscles are always in a subtle state of tonus.
Tonus meaning a baseline level of low-grade electrical contraction.
Correct. They maintain a constant subconscious tension to fight gravity and perfectly hold that 2 to 4 millimeter freeway space. You don't have to actively think about keeping your jaw from falling open. The stretch reflex of the muscles manages it automatically.
And this brings up a highly relatable, real-world physiological phenomena. We have all experienced this. You are sitting upright on a long train journey, or you're in the back row of a particularly dry, dimly lit lecture hall.
We've all been there.
You are fighting sleep, you finally drift off, and suddenly your jaw just uncontrollably drops wide open, and you wake up with a start. What is the actual neuromuscular mechanism failing there?
It's a perfect, harmless illustration of losing that baseline muscle tonus. When you cross the threshold into deep sleep while sitting upright, your central nervous system depresses and drastically reduces the resting tone of your skeletal muscles.
So the muscles basically switch off.
The moment the lateral pterygoids and the masseter lose that baseline electrical tension, they can no longer counteract the weight of the mandible. Gravity instantly wins. The jaw drops open, stretching the spindles in the masseter, which triggers a reflex arc that jolts you awake.
So we have successfully opened the jaw. Now we have to close it. And closing the jaw against resistance, biting through something tough, is a completely different biomechanical challenge. It's an active, multi-stage reverse choreography.
Closing the jaw with force requires intense stabilization. First, you have to maintain the jaw in its forward protruded position so the incisors can meet. This involves the lateral and medial pterygoids holding the tension.
The stabilization phase.
Then, the immense crushing power is activated to elevate the jaw, pulling it forcefully upwards. This heavy lifting is executed by the masseter and the temporalis muscles. And finally, once the food is incised, you have retrusion, pulling the entire condyle disc complex back up the slope of the eminence into the resting position in the fossa.
What handles that final pull?
That final, powerful backward pull is primarily handled by the deep horizontal fibers of the masseter and the posterior, horizontally oriented fibers of the temporalis.
It is a sequence of stabilize, crush, and retract. And what about lateral excursion? The movement of grinding food side to side, like a cow chewing cud. How does a bilateral, rigidly connected system move sideways?
This requires a highly asymmetric muscular firing pattern. If you want to move your chin to the left to grind food on your left molars, it is actually the muscles on the right side of the skull doing the primary initiating work.
Wait, the right side?
Yes. The right lateral pterygoid muscle contracts heavily. It pulls the right condyle and disc forward, downward, and medially inward down the slope of the right eminence.
So the right side is thrusting diagonally forward and inward.
Exactly. And because the mandible is one solid piece of bone, that forward and inward thrust on the right side pivots the entire jaw. The left condyle acts essentially as a rotational post, spinning in place while shifting slightly outward, a movement known clinically as the Bennett shift. The right side pushes to make the left side work.
That is a phenomenal mechanical visualization. Pushing the right side forward swings the left side out. Now, executing all this complex, high-force, multi-directional movement requires immaculate sensory feedback.
Absolutely.
The brain needs to know the exact micro-position of the jaw, the tension on the ligaments, and the pressure on the teeth at all times to prevent destroying the system.
The proprioceptive demands are immense. That is why the joint capsule and the retrodiscal tissues are incredibly richly endowed with sensory nerve endings. This vital proprioceptive and pain feedback network is primarily supplied by the mandibular division of the trigeminal nerve, cranial nerve 5, specifically the V3 division.
Let's trace those specific nerve branches.
The bulk of the sensory input from the posterior and lateral aspects of the joint capsule is carried by the articular branches of the auriculotemporal nerve. This nerve wraps tightly around the neck of the condyle.
In the front.
The anterior portion of the joint receives its sensory supply from the masseteric branch of V3 and occasionally filaments from the deep temporal nerves.
And supporting all this highly active neural and proliferative tissue requires a robust blood supply.
Yes, the vascularization is dense, primarily flowing into the periphery of the joint and the highly vascular retrodiscal tissue from the superficial temporal artery and the maxillary artery, both of which are terminal branches of the external carotid system.
Okay, let's zoom out. We need to look at the broader integration of this system. Because as we have established, the TMJ does not act in a vacuum.
It certainly doesn't.
The text provides a fantastic comprehensive synthesis in Table 13-1, listing the extensive network of muscles acting on the joint. And the overarching conclusion here is that there is no single jaw opener or single jaw closer muscle. Every movement is a highly coordinated team effort.
It's a vast stomatognathous web. These muscles are constantly rapidly switching roles, acting as prime movers, synergists, antagonists, and fixators in a fraction of a second.
Let's run down the functional teams. First, the closing team, the heavy hitters of elevation.
You have the masseter, the thick, rectangular, incredibly powerful muscle on the outside angle of your jaw. You have the temporalis, the large, broad, fan-shaped muscle radiating across the side of your skull.
And on the inside.
You have the medial pterygoid on the deep inside of the jaw. Together, the masseter and medial pterygoid form a powerful muscular sling that cradles the angle of the mandible, generating the crushing vertical force of mastication.
Then we have the opening team, or the depressors, and architecturally, these are surprisingly delicate, slender muscles compared to the massive bulk of the closers. You have the suprahyoid muscle group, situated under the chin, the digastric, the mylohyoid, and the geniohyoid. When these contract, they pull the chin downward and backward.
And then we have what I always consider the most structurally fascinating muscle in the entire head, the lateral pterygoid.
The maverick of the masticatory system.
Yeah.
Why is it so unique?
If you look at Table 13-1, the lateral pterygoid is the only muscle of mastication whose fibers run horizontally, perfectly perpendicular to the vertical elevators. Furthermore, it has two distinct heads that fire at completely different times.
What do the two heads do?
The inferior head fires heavily during opening, protrusion, and lateral shifts. It is the prime initiator of the translatory glide. But the superior head is different. It actually fires during closing to stabilize the articular disc against the eminence, while the heavy elevators crush the food. It's the great multi-tool, managing both opening mobility and closing stability.
And finally, reviewing Table 13-1, we have a muscle that seems almost entirely out of place. The anchor. The stylohyoid muscle. The textbook notes something functionally strange about this one. The stylohyoid isn't even physically connected to the mandible.
No, it's not.
It attaches from the skull base down to the hyoid bone, which is flowing freely in the neck. So why on earth is it listed in a table dedicated to jaw movement?
Because of the absolute necessity of establishing a stable mechanical base, think about the vectors of the opening team, the suprahyoids. They attach from the bottom of the mandible down to the hyoid bone.
Okay.
If they contract to open the jaw, but the hyoid bone is just floating loose in the soft tissue of the neck, the contraction would simply pull the lightweight hyoid bone upward towards the jaw. The heavy jaw wouldn't drop, the neck would just pull up.
So the origin of the muscle moves instead of the insertion.
Exactly. In order for the suprahyoids to exert downward force on the jaw, their bottom attachment point must be locked into place. This is where the stylohyoid, along with the infrahyoid muscles further down the neck, come into play. They fire simultaneously to pull down and rigidly lock the hyoid bone in place. They turn a floating bone into an immovable anchor.
Oh, that makes perfect mechanical sense. Once the hyoid bone is locked down by the neck muscles, when the suprahyoids contract, the only structure left that can move is the mandible. So it gets pulled down and the mouth opens.
It's a flawless example of why treating any dental, muscular, or joint issue in the head and neck requires an integrated, holistic understanding of the anatomy. You cannot just look at an isolated tooth. You cannot just look at an isolated TMJ on an MRI. You are dealing with a continuous, interconnected kinetic chain that extends from the temporal bone all the way down into the deep cervical fascia of the neck and chest.
Which brings us to the most practical, high-stakes part of our deep dive, the clinical correlations. What happens when this exquisite, finely tuned gearbox fails?
The clinical catch-all term for these functional failures is TMD, temporomandibular disorder.
The textbook defines TMD not as a single disease, but as a broad, complex musculoskeletal classification encompassing dysfunctions anywhere within the stomatognathous system. This includes the teeth, the periodontal ligaments, the joint tissues, and the musculature.
It's the very broad net.
And it points out that even microscopic structural changes can trigger a massive cascade of systemic dysfunction. Remember that 2 to 4 millimeter freeway space we talked about?
The delicate resting equilibrium.
Right. The text explicitly notes that altering that specific vertical dimension perhaps due to a dentist placing a restorative crown that is a fraction of a millimeter too high, or muscle spasms induced by severe psychological stress, or the loss of posterior teeth causing the bite to collapse, disrupts the entire kinetic chain.
Everything cascades.
The muscles go into spasm, the joint space is compressed, the disc is damaged, and it evolves into full-blown chronic TMD. The system is exquisitely, ruthlessly sensitive to spatial change.
It is. And one of the most frequent, unmistakable clinical signs patients present with is crepitus.
Crepitus, the clicking jaw. We have all experienced this, or we know someone whose jaw loudly snaps or pops every time they chew.
Yeah.
From a purely anatomical standpoint, what is actually physically snapping inside that joint capsule?
To understand the click, you have to return to our mental model of the disc and the condyle sliding down the slope of the eminence. In a healthy, synchronized joint, the disc and the condyle move together as a single, smooth, unified entity. The click is fundamentally a mechanical timing error. It is technically known as anterior disc displacement with reduction.
Meaning the disc has slipped forward out of place, but it eventually reduces or pops back into place. How does that happen?
Often due to chronic microtrauma, altered muscle tension from the lateral pterygoid, or laxity in the ligaments tethering the disc to the condyle. At rest, the disc is incorrectly positioned too far forward.
Okay.
As the patient begins to open their mouth, the condyle moves anteriorly, but it is pushing against the thick posterior band of the displaced disc, rather than sitting in the thin central zone.
So the condyle is plowing into a wall of cartilage.
Yes. As the jaw continues to open, the mechanical pressure builds until suddenly the condyle violently slips under the thick band and snaps onto the thin central zone where it belongs. The loud click or pop you hear is the physical acoustic shock wave of the bony condyle snapping over that thick ridge of fibrous tissue.
That makes perfect mechanistic sense. The sound is the joint temporarily fixing itself under pressure. Now, what about a more dramatic, catastrophic mechanical failure? Let's talk about dislocation.
Dislocation of the TMJ is anatomically fascinating because the rigid structure of the skull dictates exactly how and where it is allowed to happen. Because of the deep bony fossa and the brain behind it and the thick ligaments on the lateral sides, true dislocation functionally only happens in one specific vector, anteriorly, straight forward.
How does a patient actually achieve that?
Imagine a scenario where a patient takes an excessively aggressively large bite of a sandwich or experiences a massive uncontrollable yawn. The lateral pterygoid muscle fires intensely, pulling the condyle far forward and deeply down the slope of the articular eminence to maximize the opening.
Pushing it to the limit.
If there is a sudden spasm of that muscle or simply excessive momentum, the condyle slides too far. It literally slips entirely past the lowest, most inferior peak of the articular eminence and drops completely off the ledge into the infratemporal fossa situated in front of it.
It essentially goes completely over the cliff and falls down the other side.
Exactly. And once the condyle is over that bony cliff, it is mechanically trapped. The moment the joint dislocates, the powerful elevator muscles the masseter and temporalis instinctively go into a protective tetanic spasm and pull the jaw violently upward.
Which locks it.
This locks the condyle firmly against the anterior front surface of the eminence. The jaw is physically locked wide open. The patient is completely unable to close their mouth, swallow, or speak properly.
That is a highly distressing clinical presentation. And to resolve it, a clinician can't just push the jaw up. They have to overcome the vector forces.
Yes, you can't just force it closed.
They must physically push down heavily on the posterior teeth to drag the condyle down against the massive resistance of the spasming masseter and then guide the jaw backward, pulling it back up and over the peak of the eminence into the fossa.
You have to manually reverse the exact anatomical error.
Let's look at external trauma and the risks of surgical intervention in this area. Say a patient takes a severe, forceful blow directly to the point of the chin. A fall from a bicycle or an altercation.
A sudden, intense kinetic impact to the shin drives immense force directly backward through the rigid mandible. Now, the deep horizontal band of the lateral ligament will snap taut and protect the brain. The joint capsule will often hold.
But something has to give.
Because the ligaments in the skull base are so strong, the physical weak point in the entire system gives way. That weak point is the thin neck of the mandible, located just inferior to the condylar head. Fractures of the mandibular neck, often bilateral, are the classic presentation of a severe blow to the chin.
And the textbook highlights the profound surgical risks involved in repairing a fractured condylar neck. It is not a simple orthopedic bone plating. The surgeon is operating in a neurological minefield.
The stakes are incredibly high because the surgical approach requires navigating through tissue immediately adjacent to two vital cranial nerves. First, the facial nerve, cranial nerve 7. Its branches exit the skull and fan out right over the joint to innervate the muscles of facial expression. If a surgeon inadvertently cuts or stretches the branches of the facial nerve during the dissection, the patient will suffer an immediate, flaccid paralysis of the facial muscles on that side.
Clinically presenting as Bell palsy, a drooping mouth, an inability to close the eye.
Precisely. And the second risk is to the auriculotemporal nerve, which we established is wrapping tightly right around that fractured neck of the mandible to provide the vital proprioceptive sensory supply to the joint capsule.
And if that's damaged,
if those articular branches are severed or crushed during the repair, the sensory feedback loop to the brain is permanently broken. The central nervous system no longer knows the microposition of the joint, which inevitably leads to chronic, uncoordinated movements and severe TMJ instability over time.
And finally, the text outlines the end-stage result of these chronic issues: arthritis. If a patient has chronic TMD, a history of trauma, or a permanently displaced disc, the altered biomechanics initiate arthritic degradation within the joint space.
Yes. Over decades, the chronic inflammation and altered shear forces break down that protective fibrocartilage covering. The proliferative layer cannot keep up with the destruction. The underlying bone of the condyle and the eminence become permanently flattened and deformed. The crepitus evolves from a pop into a harsh, grinding sound, and the patient's dental occlusion, how their teeth meet, can be severely and permanently altered as the height of the condyle literally melts away.
Okay, we have covered an immense amount of anatomical and clinical ground today. Let's synthesize this into our key takeaways for you, the listener, to lock into your mental model.
Let's crystallize the absolute structural truths of this system. Number one, the TMJ is a bilateral synovial jingling orthorodile joint. Because of the solid mandible, it must be viewed and treated clinically as two joints inextricably operating as a single, unified functional system.
Right.
Number two, the articular disc is the architectural centerpiece. It completely divides the joint capsule, creating an isolated inferior compartment solely for rotational hinge movement, and an isolated superior compartment solely for translational gliding movement.
Upstairs and downstairs.
Number three, mandibular movement is never an isolated event. It is a precise, simultaneous choreography of hinge and glide mechanics controlled by a vast, interconnected web of masticatory and cervical muscles.
Stomatognathtic web.
Number four, the joint relies on a robust ligamentous network, primarily the multi-layered temporomandibular ligament, acting as the ultimate physical restraint to restrict destructive motion and protect the fragile cranial base.
Protecting the brain.
Number five, the mandibular division of the trigeminal nerve, V3, provides the dense, vital proprioceptive feedback required to rapidly coordinate this high-force system. And finally, any disruption to this delicate spatial architecture manifests clinically as TMD, painful crepitus, anterior dislocation, or degenerative arthritis.
Those are fantastic foundational takeaways. And before we move to the clinical self-assessment, I want to leave you, the listener, with a final provocative thought to mull over, something that builds directly on the tissue properties we explored today.
I'm highly intrigued. Where are we taking this?
Well, we discuss in depth how the articular coverings of the TMJ are made of fibrocartilage rather than standard hyaline cartilage, and we highlighted that vital, deep, proliferative cellular layer. This layer gives the TMJ the unique, dynamic ability to actively remodel its bone and cartilage throughout your entire adult life in direct response to the mechanical stress you put on it. It responds to how you chew.
Yes, the biological adaptation to kinetic load.
So consider our modern, globalized human habits over the last century. Consider the massive documented epidemic of chronic, stress-induced bruxism. Millions of people grinding their teeth under immense pressure every night.
It's incredibly common.
Or, conversely, consider the profound dietary shift over the last few hundred years. We have moved from a historical diet of tough, fibrous, hard-to-chew raw foods to a modern diet of remarkably soft, highly processed cooked foods that require a fraction of the masticatory force our ancestors exerted.
Oh, I see where you're going with this.
Because of that highly reactive, proliferative layer, our jaws are actively biologically responding to these modern inputs right now. By aggressively grinding our teeth in our sleep, or by barely using our masseters to eat soft bread, we might literally be reshaping the architectural slopes, angles, and fossa of human skulls over our lifetimes. Are we currently actively evolving a structurally and functionally different TMJ in real time, simply based on modern stress and diet?
That is a profound anatomical and anthropological question. Structure dictates function, but as the TMJ proves better than almost any other joint, altered function actively reshapes structure. It is a continuous, lifelong biological feedback loop.
It's definitely something to think about the next time you catch yourself fiercely clenching your jaw during a stressful daily commute. Let's
Okay.
put this mental model to the ultimate test.
Let's do it.
If a listener is sitting in their clinical board exams tomorrow or assessing a patient in the clinic, how does this complex anatomy actually present in a high-stakes scenario? We have 5 single best answer, or SBA, questions to rigorously test the anatomical relationships, functional reasoning, and clinical applications we've covered today. I will read the clinical vignette and the options, and we'll reason through the anatomy to find the answer. Here is question 1. A 45-year-old patient is eating a tough steak. During the normal, forceful closing of the mouth to incise the meat, which specific anatomical structure does the mandibular condyle articulate against to bear the heavy stress of the movement? A. The translucent roof of the mandibular or glenoid fossa. B. The thick posterior slope of the articular eminence. C. The postglenoid tubercle. Or D. The bony external auditory meatus.
The correct answer here is B, the posterior slope of the articular eminence. This goes back to the crucial misconception we disassembled earlier. The roof of the mandibular fossa, option A, is paper-thin and separates the joint directly from the middle cranial fossa. It cannot bear any masticatory stress without fracturing into the brain. To safely absorb the load, the condyle and disc must translate forward to articulate against the highly dense, thicker bone of the posterior slope of the articular eminence.
Excellent reasoning. Question 2. A 22-year-old patient presents to the emergency department in distress, physically unable to close their mouth after an unusually wide yawn. Radiographs confirm a joint luxation. Based on the restrictive anatomy of the TMJ ligaments and bony contours, where has the mandibular condyle most likely displaced? A. Posteriorly crushing into the external auditory meatus. B. Medially breaking into the sphenoid sinus. C. Anteriorly dropping into the infratemporal fossa. Or D. Superiorly fracturing into the middle cranial fossa.
The anatomically correct answer is C, anteriorly into the infratemporal fossa. Dislocation of the TMJ functionally and predictably only occurs in an anterior direction.
Because it goes over the cliff.
Exactly. A severe spasm or overextension of the lateral pterygoid pulls the condyle too far, causing it to slide unchecked past the lowest crest of the articular eminence. It drops forward into the infratemporal fossa, where the subsequent reflex spasm of the elevator muscles locks it rigidly in front of the eminence, preventing closure.
Spot on. Let's move to question 3. A researcher studying the complex synovial fluid dynamics of the TMJ. Which of the following accurately describes the strict functional biomechanical division created by the articular disc within the intact TMJ capsule? A. The superior compartment permits rotational hinge movement. The inferior permits gliding. B. The superior compartment permits transitory gliding movement. The inferior permits rotational hinge movement. C. Both compartments freely and equally share rotatory and translatory movements. Or D. The disc divides the joint vertically into medial and lateral functional zones.
We hammered this architectural division home. The answer is B. The articular disc divides the capsule horizontally into a distinct upstairs and downstairs. The superior compartment allows the entire disc condyle complex to perform translatory or gliding movement downward against the temporal bone. The inferior compartment is strictly reserved for rotatory or ginglemus hinge movement of the condyles spinning against the concave undersurface of the disc.
Perfect. Question 4. Bringing in the surgical risks. An oral and maxillofacial surgeon is repairing a severely fractured anatomical neck of the mandible following a blunt trauma to the patient's chin. Postoperatively, the patient is noted to have a flaccid, drooping face on the operated side, unable to close their eyelid or smile. Which specific anatomical structure was most likely inadvertently damaged or stretched during the surgical approach? A. The articular branches of the auriculotemporal nerve. B. The masseteric branch of the trigeminal nerve. C. The terminal branches of the facial nerve. Or D. The central trigeminal ganglion.
The clinical presentation points directly to answer C, the facial nerve. Damage to the branches of the facial nerve, which course directly superficially over this region to innervate the muscles of facial expression, results in a loss of facial muscle tone, clinically presenting as Bell palsy.
And what about the auriculotemporal nerve?
While the auriculotemporal nerve, option A, is also highly at risk during this exact procedure, damaging it would cause internal joint instability and a loss of proprioceptive sensory feedback, not a superficial facial muscle droop.
And our final challenge, question 5. During a high-impact rear-end motor vehicle collision, A passenger's mandible is subjected to a violent posterior force vector, driving the chin backward. Which specific ligamentous structure is primarily responsible for preventing the posterior displacement of the mandibular condyle through the fragile roof of the mandibular fossa? A, the deep cervical fascia of the stylomandibular ligament. B, the embryological remnant of the sphenomandibular ligament. C, the superficial oblique fan-shaped band of the temporomandibular ligament. Or D, the deep horizontal band of the temporomandibular ligament.
The correct answer is D, the deep horizontal band of the temporomandibular ligament. The lateral, or temporomandibular capsular ligament, has two highly specialized vectors. The superficial oblique portion, option C, restricts excessive lateral and downward movement. It is the deeper, horizontally oriented fibers that act as the critical safety chain, physically snapping taut to block the condyle from being forcefully driven backward into the fragile, paper-thin roof of the fossa and the brain beyond.
And there we have it. The gearbox of the human skull has been fully disassembled, the parts inspected, and the entire kinetic chain put back together. We have navigated the highly complex, multi-dimensional architecture of the TMJ, and hopefully that three-dimensional structural map is a lot clearer and more intuitive for you now. The muscular engine of the deep face generates the brutal power, but it is the temporomandibular joint that makes it human. Until next time, here are the details of this episode.
Temporomandibular joint where motion meets precision. Byline. Not just a hinge, not just a glide. This is the joint where structure becomes choreography. Episode description. If the deep face was the engine, then the temporomandibular joint is the gearbox. It does not generate force. It directs it.
Muscle contraction, E-controlled motion, force alignment, movement function, and it does this in two places at once, perfectly synchronized, because this is not one joint, it is two joints acting as one system. Key takeaways. TMJ is a bilateral synovial ginglymoorthrodial joint. Articular disc divides joint into rotational and translational compartments. Movement, hinge plus glide working together. Ligaments limit excessive motion. WeV3 provides rich sensory innervation. Dysfunction leads to TMD, clicking, dislocation, arthritis.